everyone, Alex
and Kelsey,
back again with another CDHF Talks.
Today we are talking with Dr. Turbide, gastroenterologist at the University of Calgary, about a digestive condition that you may be familiar with, Irritable Bowel Syndrome, or IBS for short. IBS is a chronic pain disorder that is very common within the Canadian population.
IBS can be classified into 4 different subtypes: IBS-C, associated with constipation, IBS-D, or diarrhea, IBS with mixed bowel habits, or IBS-U, aka unknown.
The exact cause of IBS is not clear as of yet. However, it is believed that IBS may be caused by one of several factors, which Dr. Turbide will talk about shortly. Through research within the microbiome, we are able to see people with IBS have different populations of bacteria in their gut than the general population. In terms of managing IBS, it often takes a combination of approaches, and each person may be different.
Yep, and Dr. Turbide will be walking us through all of the treatment options available for IBS, such as utilizing the FODMAP diet, antispasmodics, peppermint oil, over-the-counter and prescription medications, as well as some psychosocial interventions such as meditation and journaling.
This is one you definitely don't want to miss, so let's jump right into it.
IBS is a chronic pain disorder, and it's very prevalent, which means that it's very frequent in the Canadian population. Depending on the study, there's been about 15% of the Canadian population that suffers from IBS. Now, that's a lot of people. So 15% of the population have IBS, and there seems to be more women than men that suffer from IBS. We're not exactly sure what's the difference between women and men in terms of gut microbiome, or is it brain chemistry, or they seem to feel it more. We're not sure. There's also a possibility that women may participate more in certain questionnaires, or they may go to a doctor more. So there might be some confounding issues with that. But in terms of frequency, it's 15 to 20% of the population. And there seems to be at least 5 women for every man that has IBS. IBS is a young adult illness. So it's usually between the ages of 20 to 60 that patients suffer from IBS. And there's a big impact on society. Like, patients that suffer from IBS tend to go to the hospital or emergency at least once or twice a year in half. And most patients discuss IBS with their physicians a few times to 3 to 4 times a year. So it's something that is affecting us for work, for money. It's affecting us for visits to the emergency room, and we're often talking about it with our physician. Now, one thing that influences IBS is suffering or coping mechanisms. So there's patients that suffer will discuss it more with their physicians. So there's probably a lot of people out there with high coping mechanisms that aren't talking about it with their doctor, that aren't talking about it with their spouse. They're actually suffering in silence because they're just trying to get through their day. For the diagnosis of IBS, it is something that physicians can do positively in the office. Research has shown that family physicians in general, and I think it's just human nature, to really want to eliminate organic disease, such as colitis, Crohn's, colon cancer, celiac. And research has shown that family physicians tend to hold back from making a positive diagnosis of IBS and are always trying to rule things out. Specialists of IBS, even gastroenterologists or digestive disease doctors that see patients that are not IBS, tend to do a lot of testing. But research has shown that if you fulfill the positive criteria of IBS, there's a very good chance that you do not have organic disease. IBS, by definition, is a pain disorder. It's associated with chronic abdominal pain of at least once per week. It's also seen in the previous 3 months with a duration of at least 6 months. So you need to have abdominal pain every week for the last 3 months, and this has been at least 6 months duration. So it's usually patients with IBS have had IBS for 5 to 10 years. So it's a chronic pain disorder. It's not something that happened after you came back from a trip. It's not something that you had pain over the weekend and you need an ultrasound. So it's something that's chronic and frequent. The abdominal pain is also associated with the change of 2 criteria out of 3. So the 3 criteria are: the pain is changed with defecation. So when you're passing stool, it either increases the pain or relieves the pain. It's also associated with a change in stool frequency in terms of diarrhea or constipation. So you're going 3 times a day, you're going once a week. It's also associated with a change in stool form, where the stool is now liquidy like mush or mustard, or you're passing little pellets that are hard to push, or a very hard, lumpy stool. So you want your stool to be a nice sausage or a nice banana, but if you've got a chronic abdominal pain and it's changed with defecation, it's changed with stool frequency, it's associated with the change in stool frequency, and it's associated with change in stool form, that's IBS. And we can be reassured that IBS can be done as a positive diagnosis because if studies have shown that when you take these positive diagnoses and you remove the red flags, then the chance of finding something serious that needs to be followed up is very, very low. There was a study in Denmark looking at 300 patients, and they divided the patients into using the criteria or doing a full-on investigation, and they demonstrated that missing something serious, such as Crohn's, colitis, or cancer, was extremely low. So IBS can be classified into 4 different subtypes, and the reason that we classify patients into different subtypes is 2 reasons. Number 1 is to do adequate research and make sure that we have a homogeneous population of patients that are suffering from the same illness and can be treated in the same way. And the second reason that we do the subtypes is to classify patients suffering from the same illness in order to target treatment towards these patients. We can classify IBS into irritable bowel or IBS-D, diarrhea, if you have abdominal pain associated with a lot of diarrhea. You can have IBS-C, so IBS associated with constipation, IBS mixed, if you have both alternating constipation and diarrhea, or you can have IBS-U, or unknown or unsubtype. The IBS diarrhea and IBS constipation is very important because remember that the number 1 definition for IBS is a chronic pain disorder. Therefore, patients that suffer from diarrhea and do not have pain do not have IBS. They are often classified as IBS, but they don't have IBS. They've got chronic idiopathic diarrhea. So the chronic diarrhea needs to be investigated, and the treatment is often different than IBS-D. Patients that are constipated and don't have abdominal pain have idiopathic constipation or chronic constipation. And these patients need to be investigated as well. So abdominal pain and constipation, abdominal pain and diarrhea are IBS, but no pain is chronic diarrhea and chronic constipation. In terms of causes of IBS, I'll be honest, we don't have a clear cause as of yet, but with research into the microbiome, we're able to see changes in patients suffering from IBS and the general population. So extremely rarely there are genetic mutations that have been found in IBS, and IBS can run in families such as family clusters, family history of IBS, but there's no clear mutation that is found outside of research, and these are very rare. More frequently, though, is post-infectious IBS. So either a foodborne illness from going to a restaurant, or maybe even getting a parasite while you're on vacation and trekking somewhere. So these infections in the GI tract can cause inflammation at the gut level and maybe instigate the immune system, and then you have post-infectious IBS. So that's about 15% of patients with IBS that have a post-infectious history. Other causes of IBS would be changes in the microbiome. So we've noticed that patients with IBS have changes in their colonic flora. So when we analyze their stool, we see that their bacteria are actually different. They have less beneficial bacteria than the general population. And they have products of fermentation that are at a bigger amount than the general population. So when you eat resistant starches and soluble fibers, these products are then absorbed in the colon, and then the bacteria will then eat them and then ferment them and then produce fatty acids that are called short-chain fatty acids. And these short-chain fatty acids are good to nourish the colon. And if you're low in short-chain fatty acids, you're at risk for certain illnesses like Crohn's disease. But patients with IBS tend to have more short-chain fatty acids than the general population, and that could maybe irritate the gut and cause microinflammation and pain. So also we've done studies on doing endoscopies throughout the entire GI tract, and we've done some aspirates and some cultures, and we've noticed that patients with IBS tend to have different populations of bacteria and a greater amount of bacteria. So patients with IBS tend to have a microbiome, at least a bacterial population, that is different than the general population. Other things that is associated with IBS is psychiatric illness, such as anxiety, depression, fibromyalgia, chronic fatigue. So these entities are often associated with IBS, but I would like to note that they're not necessarily initiators of IBS, because at least 50%, if not more, of patients note that their gut pain happened before they develop the anxiety, before they develop the chronic pain. So also, when we're analyzing patients with IBS, we have to also know that there can be a lot of variability in microbiome, and the science isn't there just yet. So I can't sit here and tell you, you need to eat more broccoli and take more zinc to help your microbiome. Right now, we're at the learning stage and learning the differences, and hopefully in the future, we'll be able to change the microbiome with specific type of medications, antibiotics, or specific types of food in order to change the microbiome and heal patients from IBS. In the treatment section, I'm going to discuss a specific microbiome targeted treatment for it. For the diagnosis of IBS, it is important to rule out red flags. If you have symptoms of IBS, but you do have red flags, you might still have IBS, but I would strongly recommend discussing these with your doctor so that you can have further investigation. The red flags that I'm talking about would be anyone above the age of 50. We recommend colorectal cancer screening, be it either FOBT, so looking out for blood in the stool, fecal immunochemistry testing, a FIT testing, or a colonoscopy, anyone above the age of 50. Also, if there's a family history of colorectal cancer or polyps in a family member less than 60, you could be at a higher risk for colorectal cancer or polyps. Therefore, we would recommend screening at an earlier age. If there's a recent change in bowel habits, and especially symptoms that are affecting you at night, be it diarrhea or waking you up in the middle of the night for abdominal pain, that is not usually something that is typical. Therefore, that's something that you should discuss with your doctors for further investigation. Another criteria would be unintentional weight loss. We don't usually see weight loss with IBS. Therefore, if you do have weight loss, that is something to keep in mind. A family history of Crohn's or colitis or celiac disease is also very important, because there's a certain genetic component to these illnesses. And if you have these in your family, then these are things you need to discuss with your doctor. So in your family history, colorectal cancer or polyps, IBD, Crohn's, ulcerative colitis, or celiac disease are things that we should discuss. If you go see, you should discuss with your doctor. When you're seeing your physician or your family doctor and they're examining your abdomen, if they feel a palpable mass, if they feel something when they're examining you, that is something that is not normal and should be investigated further, likely with diagnostic imaging, because IBS is not usually associated with an abdominal mass. Another important red flag is evidence of overt GI bleeding. So passing maroon colored stool or having bloody stools or having melinas or black stools, black tarry smelly stools, this is not normal and that should be investigated further as well. Rectal bleeding, so bright red blood in the toilet bowl, may be coming from hemorrhoids, but I think that warrants further investigation as well. As a gastroenterologist, I've seen patients that were told that they had hemorrhoids for years and then they ended up having a big polyp or rectal cancer. So I think rectal bleeding should also be looked at as well. So bright red blood per rectum, passing maroon colored stool or very dark tarry stools as well. Evidence of iron deficiency on your complete blood count or CBC is not something that is associated with IBS. Therefore, that is something that it should be looked at as well. So these red flags are important. You may still have IBS, but there are things that warrant further investigation with your physician. The treatment of IBS can be frustrating for both the patient and the physician. It's frustrating for the patient because there's a lack of validation by several healthcare practitioners for IBS. It's disregarded as a stress illness. It's regarded as, just sleep better and you'll exercise more and you'll be fine. And patients are lacking validation because they're suffering and they've got a lot of issues that they're dealing with. And on top of that, they're feeling stress and they're not being validated by their healthcare practitioners. From the practitioner point of view, it can be frustrating because there's no clear blood test, there's no diagnostic imaging test, there's not a lot of positive things. You have to think from a doctor's point of view that when you do an ECG and you see a certain heart attack squiggle, then it's a heart attack. That's the diagnosis. So there's none of that in IBS, so it can be very frustrating for the physician, and there's always the fear of missing organic disease, even if the chance is very low, and study after study is demonstrating that. The first treatment for IBS is diet. So diet is something that we usually do with a registered dietitian in order to, it's not something you're going to just read off Google and start. You need to make sure that you do not have a deficiency in the micronutrients. And the diet that's been shown the best for IBS is FODMAP diet, which stands for fermentable oligosaccharides, disaccharides, and monosaccharides, and polyols. Now, FODMAP, F-O-D-M-A-P, is a diet that is easily digested. And the reason that the FODMAP works is because the foods are digested quickly in the GI tract, so they don't migrate all the way down to the small bowel where all of the bacteria are. And remember that IBS patients have a greater number and change in type of bacteria. So if you're not feeding those bacteria more, of course, they're going to feel better. FODMAP is a 2-month trial, and patients who do not have IBS don't see any changes, but patients with IBS feel better on the FODMAP diet. I would recommend this to be done with a dietitian because you need to reintroduce foods after, and I would do it in conjunction with your practitioner because FODMAP over the long term is not good. Therefore, you need to work on the microbiome at the same time. Long-term FODMAPs and other types of diets, such as ketogenic diet, are usually lower in prebiotics. So remember those soluble fibers and short-chain fatty acids and resistant starches. So those are things that are needed for your colon health. So if you don't eat a lot of prebiotics because of your symptoms over the long term, that's not good for your microbiome. Other diets that have been shown to be equal to FODMAP is gluten-free. So you don't necessarily need to go gluten-free and FODMAP. Some people are sensitive to dairy, so removing dairy as a trial is another avenue that you could try. The next classification of medication or treatments for IBS would be symptomatic relief, and those would be antispasmodics, which can be prescribed as a medication, or you can find enteric-coated peppermint oil. You can buy that at a lot of health food store, or you can order those online. Antispasmodics or enteric-coated peppermint oil work very good to reduce spasms, but remember that they do not change the microbiome and they're only for symptomatic relief. As far as probiotics are concerned, there's some studies that are showing specific types of bacteria that are beneficial for IBS, such as Bifido infantis, but these probiotics are few and far between. We're not sure how these work in real life. There's a difficulty of probiotics in terms of quality, in terms of if it says that there's 25 billion in the capsule, is there actually 25 billion in each capsule? And are these good until expiration date? So there's no clear recommendation for probiotics in IBS at this point in time. The treatment for IBS needs to be classified, as we mentioned earlier, into diarrhea or constipation or mixed type. For the constipation IBS subgroup, these patients have been shown to have a microbiome that produces more methane gas. Methane has been shown, at least in dog studies, to slow down the GI transit. So if you have a microbiome that produces more methane gas, that's going to put you at risk for constipation. A medication that has been approved for Health Canada for both constipation at a lower dosage and constipation with abdominal pain is lanaclotide or Constella. For IBS diarrhea or IBS-D, there are two medications that have been approved for by Health Canada in order to relieve these symptoms. Number one is a medication called eloxadiline or Varberzi, and eloxadiline is a novel drug that acts on several narcotic receptors of the bowel. And eloxadiline in two studies looking at 26 weeks and 52 weeks have been shown to help patients with IBS diarrhea. Now, these medications act on the narcotic receptors of the gut, so then they will decrease pain and they will slow down gut motility. So if you have diarrhea, it will slow down motility. And eloxadiline is a very large molecule, therefore will not cross the blood-brain barrier and has been shown to not affect the central nervous system. So you can take eloxadiline and not be considered on a narcotic. Therefore, you can drive and you are not considered impaired. Another medication that is approved by Health Canada for IBS-D or irritable bowel diarrhea is a novel antibiotic that is called rifaximin. Now, rifaximin is an antibiotic that is not absorbed by the gut, so 0.4% of the antibiotic is absorbed, therefore little gut absorption. And there's also an activation of the medication with bile acids, and there's most bile acids in the small bowel, of course, because most bile acids are absorbed through the terminal ileum, and therefore there's very little drug left over to affect the good bacteria in the colon. So rifaximin is an antibiotic that is not absorbed by the GI tract and is activated by bile salts, and therefore it's mostly active in the small bowel and has been shown to not influence the gut bacteria in a significant or prolonged way. Now, we always fear about Clostridium difficile infection, or C. diff, and rifaximin has not been shown so far to induce C. diff. Other medications that we can use for IBS would be mast cell stabilizers. So in patients with IBS, they tend to have, under electron microscope, a bigger amount of mast cells, and these mast cells can produce a chemical called histamine. And histamine has been shown to give more IBS type symptoms. It's also been shown to increase headaches. So you can talk to your doctor about possibly taking histamine blockers for your gut, which can be prescribed, or there's a over-the-counter medicine, a supplement called quercetin, Quercetin, that has been shown in mice at least to decrease mast cell production of histamine. The last medication that is not Health Canada approved for IBS-C or IBS-D would be antidepressants. Now, antidepressants decrease the brain threshold for pain. Increase the brain threshold for pain. So it helps with the resilience. It helps with the coping mechanisms of the pain. So if you have a lot of psychiatric illness associated with your IBS, such as anxiety, depression, fibromyalgia, or chronic fatigue, you can discuss with your physician if there's a need for the psychiatric medication. There could be, two birds, one stone, where you have the side effect of the antidepressant that helps your gut symptoms. So if you're talking about the antidepressant amitriptyline or Elavil, that tends to slow things down. So Elavil is a good option if you have IBS-D or diarrhea. And the SSRIs, such as Prozac or Paxil, these medications tend to speed things up. So the SSRIs tend to be better if you have more IBS-C or IBS constipation. One treatment modality that I haven't mentioned that is very important is the psychosocial aspect. So IBS is often associated with psychosocial, psychological illnesses, as I mentioned, anxiety, depression. So some modalities that have been shown to help IBS would be journaling, cognitive behavioral therapy, hypnotherapy, meditation. So these shouldn't be ignored. They're not, in my opinion, things that will change the microbiome in a dramatic way, but they are definitely part of a several-pronged approach with IBS. So I think the treatment for IBS is, number one, education, validation, having a discussion with your physician, and then approaching the symptoms in a symptomatic relief way, but also addressing the diet, the psychosocial aspect, as I mentioned, the lifestyle modifications such as exercise, sleep, breath work, possibly meditating, doing or seeing a psychologist for cognitive behavioral therapy. And it's not necessarily looking for a cure that's important, but I think looking for relief of symptoms, becoming to a point where you can function, and then you become more resilient and your coping mechanisms are stronger.